Stay tuned for a special presentation as On Call investigates the overuse of antibiotics. Funding for On Call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation. In 1928, Alexander Fleming accidentally discovered that mold juice inhibited bacterial growth. In 1941, the first use of penicillin became the miracle of antibiotic drugs, a miracle that requires responsibility. Antibiotic Stewardship, when the doctors are on call tonight.
One pill makes you larger, and one pill makes you small, and the ones that mother gives you don't do anything at all.
Hello and welcome to On Call Television. Lewis Thomas, a famous medical philosopher, once described the beginning of antibiotic treatment for infections like this. Here were moribund patients who would surely have died without treatment, feeling entirely well within the next day. We became convinced overnight that nothing lay beyond reach for the future. Well, not long after Thomas saw the beginning of the antibiotic era, treatment failures and resistance to antibiotics also began. The CDC estimates that in the US alone, more than 2 million people are sickened every year with antibiotic-resistant infections, with at least 23,000 people dying every year as a result, and many, many more dying from other conditions complicated by antibiotic-resistant organisms. The overuse and misuse of antibiotics is a significant problem. Research has found that over 50% of antibiotics prescribed for people are not needed. In addition, antibiotics are commonly used in commercial meat products to prevent, control, and treat diseases in animals and to promote their growth. Potentially 80% of antibiotics sold are given to animals. We're focusing on the use of humans, though, tonight. The animal issue is another story worth contemplating at a later date. To help us address this complex question of antibiotic stewardship, we are extremely pleased to have three wonderful experts from the three regional health systems that we have in this state. So let's start with Dr. Jawad Nazir. Dr. Nazir, tell us a little bit about yourself.
So as you said, my name is Jawad Nazir. I'm one of the infectious disease specialists working with Avera McKinnon Hospital and with Avera Health. So I am originally from Pakistan and came to USA in 1997. Came from part of the world where we have a lot of disease and mortality from infectious disease, the third world. So that's the reason for interest in the infectious diseases. I did my residency at University of Pittsburgh for 3 years in internal medicine, and then an infectious disease fellowship at the Cornell Medical Center in New York. And I came to Sioux Falls, South Dakota in 2003 and has been working as an infectious disease consultant at Avera McKinnon Hospital and with the Avera Health System.
That's great, Jawad. And Wendell, can you tell us a little bit about yourself?
You bet. My name is Wendell Hoffman, and I'm an infectious disease practitioner working with Sanford Health. I also am an immigrant, although I don't herald from that part of the world, but from a country up north that is noted as Canada. And I've lived in multiple different locations down in the United States. And this is my third stint in South Dakota. Moved here back to Sioux Falls in 1986. I'm married to the most wonderful woman in the world, and we have two beautiful daughters, and they've grown up in the Sioux Falls school system and are off now. And I went to medical school here at USD, and then I did my training at Mayo, internal medicine and infectious disease, and then I went out to Boston for a couple of years, and I was a consultant in infectious disease within the Harvard system at a clinic called the Leahy Clinic. Came back then in 1986 and joined then Central Plains Clinic. And so my journey has taken me over time to be with Sanford. Although I have many friends at Avera, and I would like to publicly thank Avera for opening up this beautiful venue to discuss a very, very important subject. So,
really good.
Great to be here.
Thank you. Dr. Keegan, tell us a little bit about yourself, Mike.
As the other two mentioned, I immigrated from the southeastern United States to southern Dakota about 30 years ago now.
Yeah.
And when we were assigned here to Ellsworth Air Force Base, we had to pull out the map to find out where South Dakota was. And we have loved it. We've been here 30 years now, and we're in Rapid City, part of the regional health system. And the lure to infectious disease, many of people in the audience may know Don Humphreys.
Yes.
He gave a lecture when I was an internist at Ellsworth, and I was thinking about what I wanted to do when I grew up after Air Force. So I think Don was very influential in making a decision to go into infectious disease. So we've been there working with the health department and our colleagues for almost 30 years now.
Where did you do your infectious disease residency?
I did medical
Fellowship.
school. I did medical school at Emory in Atlanta, and then
So did I.
It took me 4 years to do what you did in 2 years. And
That's another story.
another story. And my ID fellowship was in infectious disease at University of Vermont.
Great. So we have leaders of infectious disease in all three organizations, and it's such a pleasure to make a point here. I just want to say this. You know, we're doctors in this state. There's systems that work within the state, but we're doctors, and our purpose is to do the right thing by the patients, and there's never a problem between the doctors on these things, and we love to be able to interact about important issues, but there's probably really no more crisis problem right now than the issue of infectious disease. Jawad, tell us why. Well, you guys are here for a meeting for tomorrow. Let's hear about that. What that meeting is.
The meeting is about the subject we are here for, antibiotic resistance, And I think, just a brief history, we know, the antibiotics have helped cure a lot of infections, and they have decreased mortality, and illness from infectious diseases since 1940 when the antibiotics have been used, and Alexander Fleming, got penicillin in 1928, So, but over the last, I would say, last 10 to 20 years, we have seen a significant and inappropriate use of antibiotics, and what that has done, it has led to the emergence of many resistant microorganisms which are resistant to many classes of the antibiotics. So we are now faced with a situation where some of the bugs are resistant to almost every antibiotic. So you can call them XDR, or extremely drug-resistant organisms, and there are no antibiotics to treat them. So I think that's the subject we're going to discuss and meet tomorrow about.
XDR.
Extremely drug resistance. Now we moved from susceptible to multi-drug resistant, where you had resistance to 2 or 3 classes of antibiotics. Now we have moved to a phase where it's XDR, extremely drug resistant. Now it's not a local or a national problem, it's a worldwide problem. So apart from the bacterial infections, in the third world we have TB, which is extremely drug resistance, and we have malaria, which is drug resistance. We are just recognizing this in USA more when we are faced with the gram-negative infections resistance.
Well, and the CDC said Canada too. I mean, Canada, not Canada North, but
Candida.
Candida, Manilia. So a yeast infection that's resistant to everything. So, Wendell, would you say in your mind that this is because doctors, this whole problem is because doctors are treating humans inappropriately?
So, I think there are three sort of major points that we have to always keep in mind. There's the bugs, as Dr. Nazir has said. There's the drugs, for which we have a plummeting resource because the drug companies are not investing in new antibiotics. I mean, think about it. What do you think a pharmaceutical company is going to invest in? A statin that's used for 20 years, or an antibiotic that's used for 10 days? Do the math, and you can see why. Since I came to Sioux Falls in 1986, where between about a 4-year period of time, there were 16 new different antibiotics between 86 and 90. Since that time, and over the last 4 years, I believe we've had 2 new antibiotics that have come. So you can see where this is, and you just do the math.
And the third?
So the third thing is the bugs, the drugs, and then it's us. Dr. Talley, who's Dean Emeritus, famously said in a meeting that I happened to be at, he said, you know, the physician is primarily a social scientist. Now, the public kind of thinks we're scientists. In reality, we're really more like social scientists. And that simply means that we try to bring science into a social context. Because it's never just the bug and the drug, it's always the child who is spiking a fever at 103 degrees, and their parent is deathly afraid that the child is going to die. And so there are pressures on both sides. And so there's both the provider element, and then there's the patient element.
That's it. I think 2 parts to that. It's not only the doctor making the decision, but it's the mother and the father looking at the doctor going, all right.
So while the science is driving the discussion, the answer is in the social science.
Yeah. And before we do anything more, I want to say that tonight's program is being recorded at the Prairie Center on the Avera campus in Sioux Falls, and we genuinely appreciate the hospitality we've seen here and have been provided here by putting this show together. We wouldn't be able to take your calls or emails tonight, but we do have a live audience right here listening to us, and who we're inviting for questions. So we'd like to take any questions from our audience as the show progresses. And, you know, raise your hands, that works. And so grab my attention if you've got it, because we'll take any questions from our audience. We'd appreciate it. We're asking for it. And we have Lindsey out there to take your questions. So she'll see your hand raising. Okay, so what's your response to that, Mike?
Well, I think I'd like to step back and provide some context. I think South Dakota has outstanding health care. The quality is very good. The 3 systems are excellent. And I think people are very well served in South Dakota, Nebraska, Minnesota. Best quality in the country is in the upper Midwest in our region, including Wisconsin and so forth. So we're talking in relative terms here. But I think when we first had antibiotics, as you mentioned at the very beginning, they were life-saving. We had nothing before that other than very draconian measures that often weren't effective. Then as we got more and more antibiotics, we felt that we'll just use something that will kill everything, just to be extra careful. And now what we're seeing is the consequences of things, the overreach of antibiotics. And so the reason that we term this antibiotic stewardship is it's very similar to, I have a small ranch in western South Dakota. I steward the trees on my ranch. I take care of them. I try to make sure that I do the right thing for them. I don't prune them, but I do, I'm very careful with them. So antibiotics are a very precious resource, as Dr. Hoffman mentioned, that there are not more of them now. And so our goal is to try to make sure the antibiotics we have are effective for us 10 years from now or 20 years from now if we still need them. So it's a strategy that the CDC and the health department is going to ask us to do as physician leaders and as health systems, to how do we cut back on the total antibiotics used, how do we cut back on the types of antibiotics used, so that we have this precious resource for years to come.
And you said total, which means we should use them less unless they need to be used. we should use the 22 single shot instead of a shotgun.
Very targeted.
And then the third point was that we encourage people to, well, what was the third one? There was another point that you made.
Well, I think the point I was going to make was that part of this is to educate the general public to know that antibiotics are very precious resource, but at the same time, you need to ask your physician if they're prescribing an antibiotic, do I really need to have this? Are there additional tests I can have to prove this is a virus or prove this is something else, and save that resource? Because every time you take an antibiotic, there's potential consequences to it.
And as a primary care guy, I mean, you guys aren't, but I am, and I'm on the front line, and I can tell you, I feel the pressure from the patient that says, and you mean to tell me I came here, had that time in the waiting room, I'm spending the time to get it, I want to walk out of here with nothing? I can tell you I'm not going to be back to you. I'm going to go to the guy who's going to give me an antibiotic.
Well,
What's your comment to that?
I think that's why we need to work together. I mean, Lord knows the bacteria are working together against us.
They are, aren't they?
And, I don't know any bacteria that prefers Sanford versus Avera, or is going to get on actually they'll get on a car and go out to Rapid City as well.
Yeah.
So the point being that if we don't work together, then here's the social science part. If we don't work together, our patients are going to lose. And because a lot of them, and not that many of us, I mean, think of it, somebody has done the calculation, and every one of us, we have about 10 and 13 zeros following the number of cells in our body. We contain 10 to 14 zeros of bacteria. So actually, literally, we walk around and the bacteria outnumber our normal cells. So there are a lot of them out there.
And there are a lot of those bugs, aren't there?
Yes, they are.
More than there are cells of us.
Yeah, and so the approach has to be across systems. And I think kudos to you for bringing us all together. Kudos to the Department of Health for provoking a discussion that is healthy and vibrant, and hopefully this can even begin to set an example for how we ought to work together for the public's benefit and a whole lot of other issues.
Well, they say that 50% of the antibiotics we were prescribed are not appropriate.
Yeah.
Jawad.
I would like to, I just want to make 2 points, I think why this subject is so unique, One is, if someone has an acute MI, or has
acute heart attack,
whatever, you get aspirin,
yeah,
doesn't become resistant, So
right.
That's a non-infectious disease. There's not an issue with aspirin or Lipitor, or glucophage, whatever medications you use for non-infectious diseases. But that's how infectious disease is unique, because the bugs become resistant and the antibiotics become less effective. So I think that's one thing which is unique to infectious disease, why this subject is so important. And secondly, I think we're talking about antimicrobial stewardship, and I just want to define what it is. And I think there are different definitions, but the Infectious Disease Society of America, has a definition. Now, as my colleagues are suggesting, the antibiotics are useful and we need to use them. But the question is to use them in an appropriate fashion. So whenever you use antibiotics, we lead to emergence of resistance, and we have cost. Some of the antibiotics are extremely expensive. So antimicrobial stewardship is a balancing act, basically, where at one end you will use the antibiotic in the right dose, in the appropriate fashion, whatever needs to be done. But at the same time, you do it in a fashion that you de-escalate your antibiotics or narrow down the spectrum in a timely fashion, so you can minimize the emergence of resistance and also the toxicities and the cost associated with it. So that's like a definition of antibiotic stewardship. It's like a balancing act.
Stewardship. I always hear that when their church is asking for money.
There you go.
That's another story.
Yeah.
Too often, patients take antibiotics for viral infections, when in fact antibiotics have no effect on viruses. This creates the opportunity to build antibiotic resistance in bacteria. The bottom line, we are paying a cost that brings no help in return and possibly harm.
The temperature has dropped, people are gathering in their homes, and there's an increase in sneezes, coughs, and sore throats.
Definitely, as kids are getting back to school, you're seeing a lot of typical upper respiratory infections, runny nose, coughing, things like that. Quite a bit of bronchitis as well that we've been seeing in clinic.
With symptoms such as these, many people look to their physician for relief. but don't expect to leave the office with a prescription.
But majority of the cases tend to be viral, maybe as high as 90%. These infections are short-lived in that antibiotics are not needed. Patients get over them without any specific therapy.
Antibiotics are only beneficial for bacterial infections, which means that illnesses such as colds, the flu, and many coughs won't be helped with an antibiotic. Taking an antibiotic when it's not needed can add to the issue of antibiotic resistance.
Whenever in our system we have normal bacteria, whenever they are exposed to antibiotics to which they are not supposed to be exposed to, these bacteria learn how to fight these antibiotics. And so they will develop genes that will fight these infections. And these genes are actually transferred from one bacteria to the next. And so if, for example, later on you develop a true infection from this bacteria, this may be difficult to treat because the bacteria was exposed to the antibiotics before and they know how to fight them now.
Physicians are seeing an increase in resistance, and it's becoming more and more difficult to treat infections.
As microbes become more resistant to antibiotics, it becomes a public health issue. And really what happens is that they become harder to treat. In the cheaper, more common antibiotics don't work as well. That leads to increased costs, not only from needing to prescribe stronger antibiotics, but also it takes longer for patients to get over a bacterial illness.
Pepito says a major issue in antibiotic resistance is the rise of superbugs. These superbugs are resistant to our normal line of defense for antibiotics, so physicians are running out of tools to treat these illnesses.
There are more and more bacteria evolving and less drugs are being developed to treat these infections. There actually is a lobby to Congress to fund our research for the development of new antibiotics.
Older antibiotics can sometimes be effective since the bacteria may not be resistant to these. So during this season of colds and the flu, the best thing people can do is listen to their physician and be patient.
My advice would be is that if you are having symptoms that are typical of a cold, that antibiotics probably are not the best option. Trying over-the-counter medications for your symptoms, such as decongestants, medicines to help break up phlegm and congestion, are probably a safer bet. And give it time. You know, most things as far as colds will resolve themselves on their own.
And if you are prescribed an antibiotic, Dr. Pepito recommends taking the full course of the prescription. Reporting for On Call, I'm Lindsey Meyers.
We have such a great live audience here tonight. We better start with some of their questions, don't you think, Dr. Holm?
Very good, Lindsey, yes.
Do you want to stand up? Sure. What's your first name?
Tom.
And where are you from, Tom?
From Sioux Falls.
And what's your question?
Well, my question was, I have two daughters, they're teenagers now, but when they were younger, they would get the Z-Pak sometimes prescribed, and most colds are viral, but why does the Z-Pak, why is that successful in treating that?
Right, the Z-Pak, that's one of my pet peeves. Thank you for that question, Tom. Why don't you explain to the audience about what a Z-Pak is, whether that short 5-day thing once a day, so easy to take, is appropriate, and maybe when it's indicated.
It's a common antibiotic used that is easy to administer because it lasts a long time in your system, so it just requires a short course and infrequent dosing. Therefore, it's appealing for children because going through the trials of getting a child to take medication. The problem is, as you mentioned, is the vast majority of infections in children are viral infections, so no antibiotic is appropriate. That category of antibiotics has some anti-inflammatory properties, so it may help cut down the inflammation and give a perception of improvement, but actually the child is getting over the viral infection and didn't need the antibiotic to begin with. The problem, once again, is, as Dr. Holm mentioned, is the more we use of that, the less it's effective for its most necessary use, which is for a particular bacteria that causes pneumonia, ear infections, and so forth. So we lose the effectiveness of something that's very handy for children. I think the key point is we have a lot of tests now, viral diagnostics we call them, where we can do simple tests and get answers to prove it's a virus infection, and therefore reassure the parent or the patient that this is a virus infection. Antibiotics won't help that, in fact may do harm, and here's what I would expect from this course. Now if it turns into something else, here's what you watch for and let me know if that happens. And I think going through those steps with a patient or a parent helps address the concern that Dr. Holm was talking about earlier. So they didn't really work. They were getting over the viral infection about the same time you think the antibiotics are kicking in. So it gives the perception, well, that worked before, I need it next time. And so it perpetuates itself.
In fact, the studies, to hitch onto that, there have been a lot of studies done on parents and patients arguing for themselves that if they receive an antibiotic for a particular illness, they're much more likely, statistically significantly more likely to come back and ask for an antibiotic the next time around. And so there's a self-perpetuating dilemma here. There is an association between perceived benefit when actually there was probably little to no benefit, and then but that gets ingrained, and pretty soon you have a whole culture that is built within our society that seems to demand antibiotics and is, I hate to use the word hooked on, because I think providers have become hooked on just simply prescribing, because we don't take the time, because you've got physicians' offices that are driven by volume, so the physicians are paid for seeing patients every 15 minutes. They don't take the time, we don't take the time to sit down and talk with parents and with patients about some of the things Dr. Keegan was mentioning. And what's the easiest thing to do? Is to write out a prescription. And so we are very guilty on our side for perpetuating, what arguably is sometimes is a myth. And if you consider the fact that arguably 90% of upper respiratory tract infections, so sinusitis, otitis, pharyngitis, and bronchitis, okay?
Give that
those four.
Human, actual normal.
So sinusitis, sinus infections, pharyngitis, throat infections, otitis, infections of the middle ear, and bronchitis, infections of the bronchial system. If you take them all together, the data suggests that about 90% of those are probably in otherwise healthy people. Now, because if we're talking about immunocompromised patients, then the rules change. But in otherwise healthy individuals, that's about where things are at. And yet, we have developed this habit. And so the solution then has to be both helping our colleagues, our educators, and ourselves, because no self-respecting infectious disease physician can look in the camera and say, I've never misused antibiotics. We would be a liar. And if we did that, we've all done it.
We're in the social scenario.
We're looking at a mirror here when we're talking about promoting better antibiotic use. But we also need to reach out to the public and to begin to help educate them about some of these realities.
Go ahead.
Can I add?
Yeah.
So I think a key concept is a better patient-physician communication. And I think if we emphasize on patient-physician communication, where the patient family or patient concerns are addressed. Now, there have been studies which have shown that if parents demand antibiotics, physicians are more likely to prescribe antibiotics. So if the parents have an expectation, that the antibiotics will be prescribed, physicians are more likely to prescribe antibiotics. So there need to be awareness, as Dr. Hoffman is suggesting, among the physicians, but also in the community, among the general public, that for viral infections, antibiotics don't work. So I think the patients should ask this question, or the parents, is this antibiotic going to be effective or not? Is this a viral infection or a bacterial infection?
If the patient says to the doctor, really doctor, I'm not pushing for it. If you think I shouldn't have it, it's okay. Then the pressure's off. And then I can prescribe or not, depending upon what I think.
And they have studies which have stated this, that if with the parents' pressure or the patient's pressure, doctors are more likely, more than 20-30%, to prescribe antibiotics.
It's wrong too. Mike?
Yeah, there's a saying that I think helps in this situation to better understand it. If you have a viral upper respiratory infection, a cold, it takes 7 days for that to go away. With all the wonders of modern medical science, we can get rid of it in a week.
Right.
So really, there's nothing we can do.
That's right.
So don't cause harm.
Right.
If you take onto that sort of a post-bronchitis cough, for instance.
Right. Sometimes that's 2 weeks.
Yeah, exactly. So you're talking on prolonged symptoms increasing frustration in the patient. What do I do? And so they turn and say, the answer must be an antibiotic. And so I think Dr. Nazir brings up a great point that both my colleagues have, but the data also suggests that if the physician is willing to take the time and explain things, so this requires some pre-printed materials perhaps, that the patient is much more likely to go along with it. The problem becomes when we are abrupt, when we're walking out the room, talking to them and say, okay, I'm going to give you a Z-Pack, or we say, no, I'm not going to give you an antibiotic, and pretty soon they're off to somebody else. Patients trust physicians, and that's an honorable place to be. And if we're willing to take some time, again, this is social science. If we're willing to take some time, they will come on board.
But it can be so much quicker. Write the darn antibiotic and get out the door and see the next one and make more money. I mean, it's a social pressure on the doctor to go in that direction as well. And so we need not to do that. Lindsey.
We have another brave audience member. What's your name?
Dawn.
And what's your question tonight, Dawn?
My question is, on TV, they make you think that probiotics are the answers. So do probiotics really work?
That's a great question. Probiotics, Mike.
Yeah, it's a complicated question. And if I could interject before answering that question, we'd be remiss if we don't talk about how you actually prevent viral infections by getting vaccinations. So you don't get into the situation of maybe even having
and we're going to talk about harms from taking antibiotics in a minute.
And South Dakota leads the country in certain vaccinations. So
thanks to Lon Kightlinger and his team of health people.
But the probiotics are a very fascinating area in that what we're increasingly appreciating is how helpful that our normal bacteria is, as Dr. Hoffman was talking about, on our skin and our intestinal tract at protecting us against harmful resistant bacteria. And so the probiotics, which means trying to replace your intestinal bacteria with intestinal bacteria or bacteria like that, has a place, though there's a lot of studies still trying to define where that place is. We usually think about it when we're using antibiotics that cause complications. Can they undo those complications? And sometimes they do, sometimes they don't. So at least my response to that is it's still a little bit of a mixed bag.
My answer is that the scientific data that appeared at the American College of Physicians meeting was all by the people who made the yogurt. I mean, the studies were made by the people who sell the product. And so I think they're pretty weak yet. Any comments about that?
I agree with Dr. Keegan completely.
All right, this is important. We've got just about a minute before our next segment. The harms in antibiotics. Let's talk about the real harms, and we'll start with C. diff.
So I think we have talked about the antibiotic resistance, which is kind of a consequence of resistance due to use of antibiotics, but we didn't talk about C. diff. Now, you mentioned about 23,000 people dying from antibiotic-resistant bacteria, but there are 14,000 who die from C. diff every year, and there are 250,000 people who become sick. So the CDC, I think I need to mention this, CDC has just released a report, it's Antibiotic Resistant Threat 2013, which is the first comprehensive report from CDC, which kind of gives us a kind of a idea of what the magnitude of this problem is. And in that report, they have listed C. diff as the #1 public health threat, So I think just want to identify, what the issue is. Now, how that happens, I think when we take broad spectrum antibiotics, we kill the healthy bacteria. We have more bacteria in our body than the cells, and the healthy bacteria in our gastrointestinal tract, the use of broad spectrum antibiotics kill those bacteria. It leaves a place for the C. diff, Clostridium difficile, to overgrow, produce toxins which can cause severe diarrhea and colitis. And I think, I've seen patients who were unlucky to just get the worst C. diff with just one dose of antibiotic. So it's not like the repeated courses.
And it can be 3 months ago as well.
And it has another, complication associated with C. diff is the recurring and relapsing course. It keeps on coming back,
It's
and then that's
like
a tough problem.
Or something like that. Wendell, you're going to...
Well, I couldn't agree more in that report regarding C. diff being the #1 threat. It has become so significant, in fact, that C. diff is now listed and actually causes diarrhea in patients who have no pre-existing risk factors. In other words, it's out there in our community in patients who have never taken an antibiotic. And part of that is because this strain has developed, the so-called MAP1 strain, which is a hypertoxin producing strain, which began in Quebec and is literally worldwide. It's here in Sioux Falls. I think it's in our Sanford lab, something like 35% of all of our C. diff are NAP1 strains. I mean, it is here, and it is a very serious thing. And when you see an elderly woman who was given antibiotics for an episode of bronchitis, and she never met any of the criteria where you would treat, and was given 3 courses, like in this case I saw just a couple of months ago, and is now experiencing her 3rd episode of relapsing C. difficile, it makes you...
Angry.
Yes.
Angry. And we're going to come back to C. difficile and overgrowth problems and the story of the normal flora, but we need to take this. Young children commonly catch viral infections and are otherwise generally healthy and resilient. Appropriate antibiotic use includes turning down that temptation to rely on antibiotics as a cure for a viral infection when its use is more beneficial for a bacterial process. Resist the temptation, and it will help your child's health in the long run.
Children in general tend to be healthy as opposed to their adult counterparts. Adults often have what we call comorbidities. They have diabetes, they have other health issues that places them at increased risk. It comes with aging. So most children are healthy, and outside of the very young children whose immune systems are still developing, most children have robust immune systems that can help deal with infections. Now, I mentioned that children's immune systems are developing, and so some of them have not encountered some of these infections yet. And when that is the situation, then the immune system, even though it is fairly robust, doesn't have prior experience with a particular germ and cannot mount the kind of response that an older child or an adult can. Much of the antibiotics that are prescribed are for children. Children often receive more antibiotics than adults do because they get sick more often. It doesn't mean that they necessarily need those antibiotics. We know that children get between 10 and 12 viral infections every year when they're very young. And often it's difficult to tell the difference between a viral and a bacterial infection from a clinical standpoint. The physician who's taking care of that patient might prescribe an antibiotic concerned that the child has a bacterial infection when in fact they actually have a viral infection, and the antibiotic will do them no good at all. We also have the issue of families, parents and caregivers seeking antibiotics from providers. Sometimes the providers are reluctant to give antibiotics, especially if it's early on in the illness and the child is not very sick. But we have family members saying, you know, I can't go to work until my child is better, and I know they'll get better if you give them an antibiotic, whereas they don't really know that. In most clinical laboratories, it takes between 48 and 72 hours to determine if a bacterial infection actually exists in the patient, and then whether those bacteria are resistant to the routine antibiotics used to treat those bacteria or not. This is the traditional way of performing bacterial cultures and then obtaining susceptibility testing. Now, there are some newer techniques that are being developed. These are molecular methods by which we can tell very quickly, within a couple of hours, if someone has a resistant infection or not, and possibly which antibiotics might actually work for that type of infection.
So that's an interesting story about children, and it's probably where the vast majority of overuse is. We can blame the pediatricians and those family physicians, right? Not true. All of us are responsible. But I want to talk a little bit about examples of where cases have occurred that are a result of overuse of antibiotics. Jawad.
Yeah, I think probably I can mention a case, which kind of, surprised me and The MRSA, which is methicillin-resistant Staph aureus, we used to see that in the hospital settings a lot. In the last 10, 15 years, we saw an increasing rate of, MRSA infections in the hospital. But I think over the last few years, we are seeing MRSA causing serious infections from the community, patients who have not been hospitalized, not at the long-term care facilities. And most of these infections are limited to the skin, and they get drained and get antibiotics. But I saw a patient who was healthy, never being hospitalized, came to the hospital with a very bad pneumonia and developed respiratory failure, got on the vent, and his cultures grew MRSA, but that the strain looked more of a community acquired, had no relationship with previous hospitalizations or long-term care exposure. So, and that patient had necrotizing, meaning very severe, complicated pneumonia, destroying the lung tissue, and the patient, had a very bad course. But I think the point I'm trying to emphasize is the patient did not survive. Yeah.
So a perfectly healthy person came down with pneumonia, resistant to everything, destroyed
resistant to methicillin. But the point I'm trying to make is that the antibiotic use is not only in the hospital setting an issue, but in the outpatient settings. I think the point we are discussing here and trying to emphasize is it has to be done in every setting, not just the hospital setting. I think the community setting and the long-term care facility, in all those areas, there's excessive use of antibiotics, which is promoting resistance.
Wendell, you have a...
Yeah. So my case is what I just mentioned earlier.
Triple use of antibiotics.
Yes, a lady in her early 70s from northwestern Iowa who was seen for a cough kind of syndrome, really didn't even have any fever, and was prescribed some antibiotics and got a Z-Pack. And then, of course, the way we doctors like to do things, if something doesn't work, let's try it again. And so a second course of Z-Pack was given, and then a course of Augmentin was given. Well, Augmentin is a sort of a broad spectrum antibiotic, and she then, during the course of the Augmentin, developed very severe diarrhea, and of course was diagnosed with C. difficile. The problem with C. difficile is that it exists in two forms. It exists in a spore form and a vegetative form. In the spore form, it can lay on tabletops for up to 5 months. It's extraordinarily,
tough bug,
tough organism, and in patients then whose bacterial flora are changed, they become susceptible because obviously they ingest the C. difficile from somewhere, and a lot of that wear is within our healthcare facilities, which is where a lot of C. diff happens, but it's also occurring out in the community. And so this lady has now undergone she's had 3 lapses of this diarrhea. It's devastated her. As a result, our complication of treatment that initially was unnecessary.
Great story, Mike. Or terrible story.
Terrible story. Well, I think that the advantage of having gray hair is you have perspective, and I think what the 3 of us, our specialty is that we're in the hospital mainly, and we see the worst of the worst infections, and we see the complications of the antibiotics and really severe infections. And I think the perspective is the patients I see anymore, often it's to help with the complication of the antibiotic as much as it is to help diagnose an infection or to help cure an infection. And so I think we need to balance that. I just saw a lady yesterday that had a complication of an antibiotic, and that was the reason why I was asked to see the patient.
Or the allergic reactions, the whole 9 yards. Right. All right, let's switch to some questions. Lindsey.
We have some great audience questions. Few people are too shy to ask them themselves, so I'll just ask them for you. Someone from Pierre is wondering, their mother's in a nursing home and her roommate has had MRSA sores and infection for several months. What can she do to protect herself?
So MRSA sores in her mother, she's in the nursing home. What can I as the daughter do? Mike?
Yeah, that's a very good question, because in the hospital we have the ability to do isolation measures, and at home you wouldn't do those measures. You do good hand washing, you do education, so forth. So what we've done in western South Dakota is work with our nursing home directors and sort of provide an intermediate approach. We educate the patient, talk about good hand washing, but we don't restrict the rooms. So because you can't afford to in the nursing homes, they're so short, in short supply. So what we do there is just very good education, hand washing, make sure if there's any contact, that there's good hand washing, and that there's alcohol gel and rubs and so forth.
Keep your hands out of your eyes.
And just like you do at home.
Yeah.
And we found that to be helpful.
So it's a great question. MRSA is a very controversial subject now, how to handle it within healthcare systems. I mean, there are people who are culturing everybody who enter the hospital, looking for MRSA and putting them into isolation. There's a growing sense that maybe that doesn't make a whole lot of sense. And I mean, think about it.
It's just isolating.
And anywhere between 30 and 50% of the population at any one time will have Staph aureus and one of its derivatives like MRSA, either transiently or permanently. And so the point being is that example of an individual in a nursing home, she may already be colonized with MRSA. And so because it's so prevalent. And so I think it does raise what we're trying to do, what we've really heavily emphasized at Sanford, and I know Avera and Rapid City Regional have done it as well, and that is the simplest of all things that we should be doing, and that is that we wash our hands before we ever touch a human being. And so hand hygiene and how you track it is arguably the most important thing that we can do to prevent MRSA transmission or other organism transmission, either in the home, the nursing home, or in the hospital.
Huge points. We're running out of time. We need to hit fast some questions, quick answers. Good point, though.
All right, the next question is about frequent ear infections in children. Should you give antibiotics? And if you shouldn't, how long should you wait before you take your children in?
You're right, and the question, antibiotics for the ear infections, or do you put a tube and that'll save the antibiotic use?
Yeah, I think, again, we have talked about that most
Got
of
about
these,
a minute left.
Yeah, most of these infections are viral infections and they don't require antibiotics. But someone getting frequent infections may need more help, to see a specialist like an ENT to make sure there is nothing else, which needs to be investigated to see why he's having those, Giving repeated courses of the antibiotics is not the answer.
I like tubes. Next question.
Last quick question, should we be worried about antibiotics prescribed for acne? This is typical in teenagers.
Acne for long-term antibiotics for acne. Other than that, long-term antibiotics for urinary tract infection, recurrent infections in the lungs, so on and so forth. Long-term antibiotics.
I think, certainly the antibiotic treatment for acne I think it does have its place. I think there are lots of studies that show that. But I think it does bring up a point, is that when we're talking about stewardship, what we're not talking about is not using antibiotics. We're talking about not using antibiotics inappropriately. And so I think that is the point, that we should be using it. We should encourage the use of antibiotics appropriately no matter what the condition is, whether it's something as simple as something like acne, or something more serious like progressive otitis, ear infections, or whatever the condition is. I think that's the point.
It's a time, Mike?
Yeah, but I think the additional point there, and I agree, is that the choice of the antibiotic is very important. You can have some that may not be risky and some that would be more risky.
All right, great answers, you guys. We'll be back right after this.
As your baby grows, there are new surprises and adventures every day. With each new milestone, remember, immunizations are safe and one of the best ways to protect against serious diseases, especially between birth and age 5.
Now that my grandson Henry has reached his first birthday and our granddaughter Stella has arrived, we're making sure that they stay on their immunization schedules.
Schedule your children's immunizations today, for baby's sake.
Good evening, Dr. Holm and viewers. Our medical miracle is becoming a nightmare. It has been 70 years since antibiotics revolutionized healthcare and saved millions of lives. Antibiotics like penicillin, amoxicillin, azithromycin, Cipro, tetracycline, all miracle drugs have been phenomenally effective in treating debilitating and deadly bacterial diseases. We have milked these medical miracles for all their worth and more. Unfortunately, however, over the years, antibiotics have been misused, overused, and abused by doctors and patients, veterinarians, pharmacists, consumers, livestock producers, hospitals, nursing homes, and industry. All of us. Although bacteria are microscopic, they are very complex and clever. They fight back. Through genetic mutations, bacteria have developed potent defense weapons to resist antibiotics. The generation time for a common staphylococcus is just 30 minutes. Over a short period of time, these disease-causing bacteria can produce billions, trillions, centillions of new staphylococci. A slight mutation can produce the ability to resist antibiotics, which is then passed on to the next generation of bacteria. And now the nightmare is upon us. We are approaching the end of the antibiotic era. Our miracle antibiotics are becoming ineffective, and no new antibiotics are in the market pipeline. Antibiotic resistance has serious consequences as infections become more difficult to treat. Procedures like organ transplants and cancer treatments are prone to bacterial infections and becoming much more difficult to manage. And antibiotic resistance is not something found in some far-off country. We are seeing antibiotic resistance right here in South Dakota. This is our problem. Here in South Dakota, we have urgent threats of carbapenem-resistant Enterobacteriaceae. There are 7 things that we as citizens can all do. First of all, be aware that antibiotics are not useful for viral or fungal infections. Secondly, discuss your treatment with your doctor on why or why not antibiotics are being prescribed, and then follow the guidelines for their use. Thirdly, don't pressure your doctor into giving you an antibiotic. Fourthly, use antibiotics only when necessary. You don't need antibiotics to treat the common cold or influenza or your child's green snot or mini urine infections. And then if you're prescribed antibiotics, make sure you take it until it's finished, not just take a few pills and then quit. But if you have leftover antibiotics, dispose of them properly and safely. And lastly, as always, practice a healthy lifestyle.
No, we really appreciate Lon Kightlinger and the South Dakota State Health Department, and the vaccination rate in South Dakota is on the top of the country, and it's because of the leadership that we have in our state. It's a fabulous thing. Very quickly, let's talk about what good stewardship can happen. I mean, we've got some data in there, don't we? We've got countries that have proven that if you cut back, the resistance goes away. What do we know, Mike?
No, absolutely. Probably 10, 12 years ago, the thinking was that once this happens, it's the new normal. But I think there's been several studies, a very good one out of Paris. The Netherlands are doing some excellent work. Western South Dakota, we dramatically cut back on some antibiotics and shown that you can reverse the rise of MRSA and some of the resistant bacteria, C. difficile and so forth. So it's not a hopeless situation. The stewardship concept does work if applied.
It makes a difference. Wendell?
Yeah, I think that the data are clear. That if you use antibiotics in wiser fashions, the bacteria tend to return to their more natural state. And the other thing that this reminds me of is that we can impact our hospitals where the sickest patients are by using antibiotics better out of the community, because the community use actually affects the hospitals. And so that brings up my third point briefly, and that is, and I think Dr. Nazir referred to it, antibiotics are the only class of drugs where what I do affects you. So if I take a statin or an aspirin, baby aspirin, you're not affected. But if I take an antibiotic, because if I shake your hands,
oh gosh,
we have just shared organisms, and that's what happens. We tend to do this because we're social animals.
Yes.
So I think great points. But I would like to emphasize that if there's so many studies out that good antimicrobial stewardship programs can decrease the resistant rates. Now we have to also understand that by decreasing the resistant rates, mortality decreases too, and the length of stay in the hospital decreases too, and hospitalizations decrease. So I think the consequences of the successful antimicrobial stewardship program cannot just be decrease in the resistance, its cost, its hospitalization, its duration of the illness,
Okay, so we got 10 seconds. I want to make a comment. We need use of antibiotics in animals to be also responsibly used. Do you guys agree with that comment?
Oh, absolutely.
Well, look at it. I mean, we use 6 million pounds of antibiotics in the United States for human beings. We use 26 million pounds of antibiotics for animals. Case closed.
Case closed. Well, this brings us to the end of our show this evening. I sincerely thank Doctors Nazir, Keegan, and Hoffman, our guests and friends, for helping to answer all the insightful questions from our audience tonight. I'd also like to thank our piano player, Camille DeVore, who played piano music before the start of our show. Mark Twain knew that every decision we make has potential when he said in his autobiography, "We recognize that there are no trivial occurrences in life if we get the right focus on them." Until next time, stay healthy out there, people.
Funding for On-Call Television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
Funding for On-Call Television is provided in part by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On-Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.